Here we are. Thank you very much for your talk. Doug's very much given us the big picture, and I'm focusing now on the global mapping of mission and church hospitals. And as Doug has said, my background, I'm from New Zealand originally, trained in general surgery, worked in Africa, but then have been 27 years with the CMF of the UK, which is the equivalent of CMDA. And I'm now, for the last 18 months, CEO of ICMDA, the International Christian Medical and Dental Association. So a little bit about us. Our vision is a Christian witness through doctors and dentists in every community, in every nation. So very much Acts 1:8 as applied to medicine and dentistry. But our focus is on starting and strengthening national movements of Christian doctors and dentists. So on organizations rather than individuals, although that boils down largely to leadership training and development. And we aim to organize networks, communications, events, in order to facilitate calling, equipping, fellowship, and service. This is the map as we see it. So the green countries are those which have an affiliated national movement with ICMDA. The orange, where there's a national movement moving towards affiliation. Individual contacts in the blue countries, and the grey, where we don't yet have contacts. And so our network is 84 national member movements. In total, 12 joined at the last World Congress in 2018, representing altogether 7,000 doctors and dentists. There are 28 national contact groups that we're hoping to invite in at the next World Congress in Tanzania in 2022, and we have individual contacts in 30 other countries. So together, nationally and internationally, we're running about 100 events, either from the national level up to regional. We have just 3 paid staff, and our field workers are all doctors and dentists in full or part-time work as tent makers. So how did we get interested in hospital mapping initially? Well, it was suggested to us that when the US pulled out of the WHO, the USAID was looking for new partners and that we should make a submission. So we did that along with, I think, many thousands of others. And we had a fairly grandiose vision initially with all our partner movements to, you can see here, to build the capacity of church and mission hospitals in Africa and Asia urgently in preparation for COVID-19, to establish these church and mission hospitals as sustainable learning institutions of the future by building their capacity and resilience, and to influence national policy and guidelines through role modeling and establishing best practice models and centers of excellence. Now, of course, this is a huge vision far beyond our resources. We really just wanted to communicate that and then find a project that we could deliver in it. And we identified these issues back in March: lack of appropriately trained staff, IT facilities, medical equipment, of course, everything from PPE to ventilators and oxygen masks, lack of bed capacity, and also the acute financial needs. And Mike was mentioning the case study in Pakistan recently where being not able to run outpatients or elective surgery, they were hit with a huge fall in income. So these were some of the issues, and these was our initial suggested strategy that we use training materials that have been developed by one of our partner hospitals, Christian Medical College in Vellore, for online plus face-to-face training in COVID preparation for hospitals, that we train trainers from individual places, that we facilitate that with face-to-face training. And then these other things were later, if we could find appropriate partners, equipment, IT support, financial support. And so the initial stage of the project was to identify needs for which we needed a database, which we did not have, of church and mission hospitals in Africa and Asia, to survey them, to assess their needs, to draw up a project plan and find partners, and then specifically to provide online staff training and management protocols through training of trainers using a course which had already been developed by Vellore in partnership with the Tata Foundation in India, and was already being rolled out in India. So our vision was to take that more globally. Well, of course, as you might expect, possibly with all the demand, we had no response from USAID or from any other funders we'd approached. And so we had to ask, well, do we just give up on this idea, or do what we can with the resources that we have? And so we decided to downsize the project to focus on the construction of a church and mission hospitals database, to survey them with respect to needs, and to provide free COVID preparedness training, or training of trainers. And so we had just one part-time staff member and some volunteers, and we negotiated with CMC Vellore and the Tata Trust for them to train 200 healthcare professionals in Africa and Asia outside India, free of charge, by the end of this year. Now, the big question, of course, is why map church and mission hospitals at all? And I think that Doug's already made a fairly convincing case for this. It's not just about wanting to know where everything is, but what's the purpose for it? And these were some of the needs we recognized. If such a database existed in one place, what it could be used for: to assess needs for training, IT, medical equipment and personnel, especially in the light of COVID, to later on carry out research into developing world diseases, with a shift to non-communicable diseases, much more research needed, to identify real centers of excellence for capacity building and role modeling, to identify trainees for postgraduate medical education in family medicine and specialties. So these were qualified doctors working in mission and church hospitals who only had an MD and nothing else, and needed their own skills built. To provide data and information, to identify projects for fundraising, to encourage networking and cooperation, but also to assess the need for advocacy, to see how we could, with partners, be a voice to power for hospitals facing challenges in very remote areas. I've just come to this conference of an ICMDA seminar or webinar, which was broadcast all around the world, where a past director of Christian Medical College Vellore, who's now running a small mission hospital in the northeast of India, was describing how they adapted to the wave of COVID with absolutely no resources, and needing voices to empower and protect them. So those are some of the reasons overall, but for us, we had a specific focus and interest that really boiled down to just these three things. We wanted to provide training in COVID preparedness for hospitals who wanted it. We wanted to identify candidates for our own international postgraduate diploma in family medicine. And we also wanted to identify Christian doctors and dentists that we could help mentor, train and support in the future. So that was our reason. So had there not been COVID anyway, we probably would have done this for reasons 2 and 3, although COVID was the prompt to think about it. So first of all, this preparedness training for hospitals. CMC Vellore developed a 9-module online course, which they were already rolling out in India. They offered us 200 free places. It consisted over 18 days of two to 3 hour online sessions live, but all of the rest of the course could be done in people's own time in their particular time zone, and leading to an examination and then certification as a trainer, whereby they could then take on 4 or 5 others using the same material every 2-week cycle. And CMC have now developed a shorter 6-module course for those from hospitals without intensive care facilities. So this initial course was everything from isolation and triage to oxygen therapy to intensive care. And so this describes the course program, and you can see here that the 9 modules, and each one breaks down into 4 or 5 sub-modules that people do online, 20 to 25 hours over 2 weeks before their examination and final certification. And so in order to choose people for this, we were to approach the hospitals and ask them to fill out a form about their hospital, beds, staff, equipment, what they needed, who would be the trainer they'd like to nominate. Secondly, it was our postgraduate diploma in family practice, which was a partnership, or still is a partnership, between CMC Vellore, ourselves, and Loma Linda University in California. And we launched this in the middle of COVID in May this year with 32 students from 15 countries. It's a 2-year blended course leading to international postgraduate diploma, taught over 15 modules over the 2 years, with contact sessions held for skills training in 6 centers in Africa and Asia. So our aim was to start this year, start another lot next year, and then gradually enlarge this with more contact centers. And then our third reason for doing it was to help Christian doctors and dentists to grow in their faith and in their integration of faith and practice. So we had an online learning program with lots of resources and courses, and we wanted to find people who would benefit from it. I mentioned our webinar program as well. We run these between 100 and 300 people from up to 50 countries every week on subjects at the moment which are relevant to COVID. And so our methodology, how do we define a church or mission hospital? Well, we decided at the beginning, any institution that's got inpatient facilities where people can stay overnight. So it was a reasonably loose definition. And we aim to approach members of CMF UK and CMDA US, to approach international mission societies, the CHA groups, and also to use the internet, websites, Facebook pages, Google, and so on, every means possible. And so we set up an answer for expatriate missionaries working abroad who could come and give data about their hospital that could go into the database. But most of the work was actually done by contacting these other organizations and finding the hospitals individually, and then putting everything into a whole series of Excel spreadsheets initially, with a whole lot of parameters that we were looking for. So where have we got to so far? Well, we're still very early in this project, and we've not had a lot of manpower, but we have completed data collection in 21 countries. We've got 14 more in progress. We've identified 700 hospitals so far from 57 countries, because we've been given information that we haven't yet actively sought. And that only includes 32 hospitals in India. And we know that there are probably about 750 Indian hospitals under the umbrella of the CMAI, Christian Medical Association of India, and the CHAI, the Catholic Health Hospital Association of India. So we know already that there are at least 1,500 church and mission hospitals in Africa and Asia. We've tried to go for the low-hanging fruit first, the countries where there are most of them. And of these, we haven't got contact details for all, but we have been able to survey 334 in 2 separate mailings. And this is just a summary of the data to give you the big picture. So of the hospitals that we've identified, 700 hospitals altogether. These are the biggest ones in Africa. So we've got Ghana, which tops the list, Zimbabwe, Kenya, Nigeria, Zambia, Malawi, and Tanzania. And then whether we know the number of beds, the director's name, the director's email, the address, whether we have a phone number, and so on. In Asian hospitals, 97 altogether. You can see only a few in India, because CMAI was, and the Tata Trust and Vellore were already doing training there. We did not prioritize India, but rather prioritize the other countries. See, Pakistan, Nepal, and Bangladesh are the biggest ones. And then, although we hadn't sought this, we'd been sent some information about hospitals in other areas of the world. So just over 20 of those. So in summary, 334 hospitals approached regarding their COVID needs on the 18th of August. 31% opened the email, 6% clicked on a link. And there we have one of the big problems in data gathering. We had 46 survey responses, We have identified 38 doctors to start the course. 18 have started, 5 have completed, and we, as I say, hope to have 200 in total trained by the end of December. So we've got another 4 months to achieve that. These are just some of the responses. You can see an open rate of 31%, click rate of just 6%. So it tells us that emailing hospitals is not a good way to find recruits. So in summary, the data is available in the public domain or from CHAs, but details are often difficult to gather. Even they may not have them. We've got a database of 700 hospitals from 57 countries. Maintaining it is going to require more resources and commitment, poor responses to surveys, and sadly many of those who request training even and fill out the detailed questionnaire do not turn up for the online sessions or see it through to completion. And the picture we get is of people in large part, especially in Africa, overwhelmed by other medical needs, not yet having encountered COVID and not seeing it as relevant to take time to prepare for it. So just my final slide now, how we're going forward to keep building the database. We want to get to 1,500 hospitals from 70 countries by the end of this year, to take on a full-time administrator to help us with that process, to build better links with the CHAs, international mission societies, to continue to roll out the training for COVID preparedness, and the IPG DFM, the family diploma, or the postgraduate diploma in family medicine, and then to work with the CIH consortium, which Doug has been describing already. So I'll just stop share and pass back to Doug.
Thank you, Peter. That's fantastic, and we're really grateful for that. It's amazing. Peter, how long ago did you start this initiative?
About 2.5 months ago. So with one part-time staff member working 1 day a week, but with half a dozen volunteers, some of whom were great hunters of data.
So this is part of the miracle of what you've been able to do is you just said, oh, we can answer some of this, and let's just get to work on it. And so instead of it being too large of a problem, you took it on and bit off meaningful parts of that. So I just wanted to celebrate that. We only have 4.5 minutes. I would love any questions. There's only one written in here, which is Peter, to get some description of the process for ICMDA membership for Thailand, Cambodia, Laos, and other places. I don't know if this venue and time will give you enough to answer that, but you might want to say one thing about that and then contact Neil afterwards.
Yes, well, our field workers, we have 45 of them, are key. So they establish contacts with individual Christian doctors and dentists, encourage them to form a national group, walk them through running conferences, running events, and so on. And then we talk them through the process of joining ICMDA, which only happens every 4 years at the World Congress, where we welcome new groups. So 12 last time, we've got a target of 16 for this time. And one of those, two of those, Thailand and Cambodia, are on our list. And in fact, just this last week, I was on a 1.5-hour conference call with 5 leaders of the Thai Christian Medical and Dental Group, and along with 3 of our field workers, just talking them through that process and answering their questions. So we try to be as proactive as we can in identifying their needs and seeking to start them and then strengthen them and then affiliate them to ICMDA and bring them into the wider family.
Great. Feel free to come off mute if you have a question and just raise it here. We have just a few minutes, just under 3 minutes.
Peter, just give us a sense of your passion out of, I mean, I think we see your passion, but the biggest thing, you know, what's impressed you the most in terms of the needs of the health professionals that you have been able to connect with? What's on your heart as some of the biggest, most important things?
Well, in the context of COVID, I think it's just that in many places, but particularly India. People are just absolutely overwhelmed. In people's words, they've given up now. The government has made a number of unwise decisions, particularly sending vast numbers of migrants back. And now COVID is there in every rural area, every hospital, not just the cities, but the towns and villages as well. And they are just overwhelmed. And the greatest need is for good leadership and good training. And so I think this training has come at just the right time. A lot of the needs there, I mean, they need money, obviously, their income's being hit, they need resources. A lot of those resources they can create for themselves. They're incredibly resourceful and they need a lot of prayer support. So I think that's the COVID picture. But I think generally our focus very much is on, in order to produce a Christian witness, our dream is, a doctor and dentist in every community and in every nation. And we think that boils down to leadership training and development. So it's about identifying nationals who really have gifts and who have the call of God on their lives, and helping to understand what they need and then resourcing them with the training and help that they need. And one of the reasons we're focused on this International Diploma in Family Medicine is because there are so many doctors who have medical degrees but have had no good postgraduate training, and they're serving in mission and church hospitals. So being able to upskill them and give them much more in the way of resource and ability, we think is one of the best ways of developing strong health systems.
How many what proportion of the agencies that are out there, let's just say the mission agencies that we're aware of, many of which are Western, sort of share that vision? Would that be small, medium, or large numbers?
15 seconds, Peter.
Okay, I think what struck me is how few of these 1,500 hospitals are actually attached to any international mission agency. It's a very small percentage. There's some great centers of excellence, but it's the